So good to go.
Yeah, good evening, friends. Welcome to the Tuesday Critical Care and Emergency webinars, which Yashoda Group of Hospitals regularly do. And today we have an interesting area. We have been probably focusing more on heart attack, cardiac cell is equal to time, time is heart. And now for the last few decades, the brain cells has been also focused in the same way. If you time is equal to neurons and time is equal to neuronal cells. So we have one of the leading interventional and both neuro and vascular interventional radiologist, Dr. Suresh Giragani, good friend of mine and a good colleague of mine who have been working since maybe a few years together in the previous organization and currently in Yashoda Group of Hospitals. So we will be discussing today about mechanical thrombectomy. From our medical school days, we initially thought about just antiplatelets and conservative supportive care for all the ischemic stroke patients. Then later in our post-graduation days, we came across thrombolysis as being an immediate intervention if the patient reaches in a window period. From thrombolysis, out of the window period and during the thrombolysis, non-canalized vessels can we do one step ahead. And the last decade have been the literature which is pouring in support of mechanical thrombectomy, which is an intervention which can recanalize these vessels where we can save neurons and we can back the functionality of a patient. And on this aspect today, we have Dr. Suresh Giragani, our neuro and vascular interventional radiologist, who will enlighten us with his vast experience in this field. And we are fortunate enough to actually witness those experiences. And then we wanted all of you to put your queries and suggestions and points in this debate so that we can interact with Dr. Suresh Giragani. Now over to Dr. Suresh Giragani for his presentation.
Good evening, everyone. Thank you, sir. Thank you for the kind introduction. It's been a pleasure and it's pleasure sharing the dais with you on this symposium on stroke interventions. So I'm a consultant vascular and neuro and vascular intervention radiologist at Yashoda Hospitals, Secunderabad. So today I would be focusing myself on the role of the particular procedure, that is the mechanical thrombectomy. Just like the primary PTCA what do for the heart attack, and we have got this particular treatment that's been approved in the world over in the last 5-6 years, and its current evidence and what's our own experience in our single institute. So that I will be elaborating in the next 20-25 minutes. So in this topic, I'm going to discuss about the large vessel occlusion. This term is I'm going to repeat again and again that because we are going to treat our treatment is limited to large vessel occlusions, not all the strokes. So what is the epidemiology of large vessel like occlusions and their natural history, and if you don't treat, what will happen if you treat, and what is the incidence, everything I'm going to discuss, and few of the basics about the imaging and how do we select the patients based on the imaging, and some basic anatomy and indications, how do you go about in selecting those patients. And then I will discuss about the stroke code and our execution of the stroke protocol in our own setup, and how do we do triage of our stroke patients and current evidence and our experience in approximately 120 cases. I will be briefly describing each of them. So you all know that stroke is of high incidence, especially after COVID, and especially in young patients. We are seeing more and more thrombotic complications, not only in visceral circulation, pulmonary circulation, but also in neural circulation. Also, we are seeing more and more thrombotic complications. So coming to the basics, so we have strokes means any sudden loss of function of the brain. So it has got two types, as you all know that when it's leaking, it's called as hemorrhagic stroke, and when it's occlude, the blood vessel is occluded, this is called as ischemic stroke. Incidence is very important. Incidence, the ischemic stroke is 85% in incidence, whereas the hemorrhagic stroke is quite rare as compared to ischemic stroke. So this is 15%. So coming to the stroke types, this is very important. Our role is concerned with the large vessel occlusion, as I said in the first slide. So large vessel occlusion means that you have a large area of infarct, or a small area of infarct with a large vessel occlusion. So you need to do two imagings for that. One is the CT angio or the MR angio, along with the parenchymal imaging in the form of either CT or MRI diffusion. So once you do both of them, then you can give a diagnosis of large vessel occlusion. The other stroke types that that have been described in the literature, as a physician, you almost be knowing that the other types are embolic stroke, lacuna stroke, and stroke of undefined etiology. So these are the various types of stroke, and our role lies in the large vessel occlusions. So what are the areas that we usually touch, or the vessels we touch? The vessels which are 2 mm or more in size in diameter, those are the areas which touch. And the vessels we touch are like ICA in the anticirculation, and in MCA proximal M1 MCA and proximal M2. So these are the areas that we go and try to recanalize the occluded vessels, beyond which the technology is not yet approved, or it is in place but it's not approved yet. So we go up to proximal M2, as well as the M1 MCA, and as well as the ICA we try to recanalize. So this is about anticirculation. And the other types of strokes are also important, because if you see an infarct, it doesn't mean that you always find a vessel to be occluded. It's not the case, as you see in this case. He has got a lacunar stroke in the centrum semiluval adjacent to the cardiac body. And if you see the MR angio, then you have normal MR angio. So the level of occlusion must have been in a small perforator artery that is causing the infarction, although it is disabling or debilitating. You may find the artery is normal, and there is no role of intervention in such kind of cases. So you need to have to do a stroke intervention, basically you need to have a large vessel occlusion. Large vessel occlusion means the either ICA or the M1 MCA or the proximal segment of the MCA need to be occluded. Then only we can go and intervene. And the second component is we need to know is that parenchymal imaging, or the parenchymal damage, whatever patient has come to emergency and we have done the imaging. By the time the patient reached the imaging section, so what kind of damage the brain has already taken, what amount, extent of the damage the brain has already taken, that is very important. So to quantify it, or to kind of reproduce the overall findings, there is scoring called as aspect scoring, which is coined by the Alberta group of stroke specialists. And it is basically done on CT, but we can do it on diffusion MRI if you are going by MR diffusion protocol. And so there are 10 areas we need to take into consideration, 10 areas. So how do you calculate? You need to take the CT section or the MR section, which is at the basic ganglion level, and one at the supraganglionic level. So the cortex, the MCA, basically it is for the MCA territory. The cortex is divided into 3 wedge-shaped areas. The anterior one is called as M1, M2, M3 at the ganglionic level. The other one is at the supraganglionic levels, again saying that M4, M5, M6. So these are 6 areas total. In addition to that, we have 4 areas for the ganglia. One is carotid, putamen, and insula, and the other one is internal capsule. So there are total 10 areas that are to be counted to evaluate the extent of MCA infarction. And the aspect score is given as total areas involved to be subtracted from total number of 10. So suppose if you got 4 areas already involved in the ganglionic level as well as supraganglionic levels, so the total score of the aspects come as 6. 10 minus 4 is equal to 6. So that's how you need to calculate. Few examples. So this is, you see that the putamen is the only area involved here. The supraganglionic level of diffusion was normal, so I didn't put it here. So his aspect score is going to be 10 minus 1, because only one area is involved. So we got 10 minus 1, that is 9. So another example, here you see that 4 areas involved. The anterior portion of the MCA at the ganglion level is also involved. In addition to that, you have the involvement of carotid and the putamen and the insula. So that there are total 1, 2, 3, 4 areas that are involved. So 10 minus 4 is equal to 6. So this is how we calculate the aspect score. So how it is important? So means that you are quantifying the extent of a MCA infarction that has already happened. So the trials and the intervention trials, as well as the thrombolysis trials, what they say is that if you are doing the kind of proposing recanalization in MCA territory or ICU territory, if the extent of infarction is such that the aspects is, if it is 6 or more, that means if it only 4 or less areas are involved, the outcome is going to be good. It is as simple as that. If aspects should be 6 or more, that means 4 or less are areas to be infarcted to be taken for intervention. So if more areas of the involvement is there, if you do intervention, what will happen? The benefit is not going to be as much as that of the patients you have done for aspects of 6 or more. So the more area of infarction that you have, automatically the aspect score will come down. Maybe it will come down to 4, 3, 2. So the more the aspect score is, the lesser the damage in the brain. And if you do intervention, the outcome is going to be better. So the aspect score is directly proportional to the good outcome. So the aspects as well as the vessel imaging, both are the basic parameters that we take into consideration before selecting any patients. So what is the rational stroke intervention? So whatever the patient who comes to the emergency has got an established infarct already in the brain, so that is called as core, and there is an area of brain that is perfused by the collaterals, which is like about to die kind of the brain tissue. If we salvage that part of the brain by opening up the blood clot proximally, then this part of penumbra, this part of the borderline perfused tissue will be saved, that and his overall outcome is going to be improved. So the core remains infarcted, but the penumbra will be salvaging. So we need to see how much is the core and how much is the penumbra. If core is more than the penumbra, or penumbra is very negligible, there is no point of intervention. And if the core is less and penumbra is more, then obviously the intervention is going to have a definitely role. So how do you calculate that? So basically, I go by basically the infarct core that is estimated on aspect scoring. So I don't do penumbral imaging unless until it's very if you're not very sure about the infarct core. But automatically, if you have an area of infarction, area of territory of supply of the MCA is this much, and you have got only 2 areas that are involved, that means the rest of the areas definitely can be spared. So the rest of the areas automatically represent the penumbral tissue. So this is the graphical representation. If this is the area of infarction that happened and the patient is having already an ICU kind occlusion or the proximal M1 occlusion, then the rest of the territory that can be salvaged is this much of territory that is going to be infarcted if you don't do anything, is going to be salvaged. So that is the concept of penumbra. And so to conclude, in whom it is beneficial. So patients who are having small infarct cores at presentation or the large penumbra, that both indicates the same, and accessible corresponding large vessel occlusion and good collaterals. If the patient is having good collaterals, he will give some time. He will give some time till the patient is taken for intervention or thrombolysis. If the patient is having poor collaterals, the surrounding tissue is going to die down very fast. He's not going to have, is not going to be too much of time for intervention. So this is very important to know that whom it's going to be beneficial and in whom it's not going to be beneficial. So this is what is included in the guidelines, which have come up in 2015, further updated in 2018. And there is a class 1 evidence for this particular treatment. And number needed to treat is also very impressive, like 2.6 is the NNT, number needed to treat for these kind of interventions, which is more than that for the primary interventions for the cardiac interventions. So patients who are of more than 18 years and who are having NHS score of more than 6 or more, and aspects of 6 or more, and patients who are having the pre-stroke MRS of 0 to 1, these are eligible candidates up to 6 hours. That was the guideline that was given. And treatment, if you can initiate the treatment within 6 hours of the symptom onset, then the thrombectomy is going to be beneficial. And for this, there is class 1 evidence. And IV thrombolysis, if large vessel occlusion, if the patient is coming in within 4.5 hours, IV thrombolysis can be started, and after that MT to be added. So this is the ideal case to be selected. So this is how we go about. Either we can go with CT or MR and you rule out the hemorrhage. And if the patient is within 4.5 hours window period, start the thrombolysis, do an angiogram. If you see in large vessel occlusion and good collaterals, go for thrombectomy. And if the patient is coming beyond 6 hours, then you do. I personally prefer MR imaging and MR core I see, and I don't depend much on the perfusion imaging. And if the infarct core is small, then I will go for thrombectomy if there is large vessel associated or large vessel occlusion. So what we do technically to graphically represent it, 2 types of devices. We have a basket kind of device which retraces of the thrombus into the guiding catheter from the groin. So this is called a stent retriever. The other one is the suction device. This is called as the adapt technique, wherein we pass a large bore catheter that can be passed into the intracranial vessels, and it will try to suck out the clot through a suction mechanism. So we'll try to use both the devices in combo because it increases the efficiency of the retrieval and increases the overall outcome of the technical outcome. So coming to the evidence and guidelines. So as I was saying that we have got role only in large vessel occlusions. So what is its exact incidence in stroke patients? So in Indian patients, it's been described as around 10 to 15%. And this is one of the French study recently published in Stroke Journal. So they said that a visible large arterial occlusion was seen in around 29% of patients in a total population of this population study of all the stroke patients who were screened with the angiography study as well as parenchymal imaging. So out of 971 patients, they could find an arterial occlusion 29% of patients, and proximal vessel occlusion, which are amenable for intervention, was seen in 17% of cases. So we are talking about around maybe to every 1 in 5 patients. Every one patient of a stroke patient, acute stroke patient, will have a large vessel occlusion, and he is an eligible candidate for intervention if he comes in the window period, and if he has the small infarct core, and he gives time for if his brain parenchyma gives time for the rest of the salvage of the rest of the penumbra. So if you don't treat it, that's like if you this is what the patient is going to ask. If you don't treat it, what's going to happen? And if the patient comes, most of the patients who are having penumbra on the initial hours, they will be kind of moderate disability they will be having, but in the next 2-3 days they are going to worsen because of the swelling and because of the brain edema and because as well as the dying down of the collaterals and the expansion of the overall infarct. So these are all the causes of the development of malignant infarction that will happen if you don't treat it in the next 2-3 days. So that is the nature list of large vessel occlusion. So the overall bad outcome at 3 months, either mortality or morbidity more than MRS more than 3, so almost 65%. That means only one patient out of three patients is going to have a moderate favorable outcome, whereas 2 patients are not going to have a good outcome. Either they will be dependent or die at 3 months of the after onset. So the evidence says, and the evidence guidelines have come up in 2015, and there were the multiple trials. The trials were there since 2000s or late 99s, but with the advent of the more neuro-specific stent retrievers, as well as the thrombectomy catheters, the outcomes, technical outcomes are better. Apart from that, the imaging selection is also become better because of more better understanding of the collaterals, better understanding of the penumbra. So previously it used to be a random inclusion of the patients, but now it is more imaging-based protocol that we follow at our institute also. So the 2018 guidelines are the standard guidelines that we follow here as far as the selection of the cases is concerned. So the landmark trials in stroke, the NINS trial, which approved the IV altiplase up to 3 hours, and after that ECAS 3 trial gave the approval extended up to 4.5 hours. That was in 2018. And 2015 was the landmark year for stroke interventions. And there were so many studies and randomized trials in the number of around 6 to 7 have come up, all with good results, which suggested that you can go for thrombectomy up to 6 hours. And in few selected patients, you can go up to 24 hours was given in patients included in the category in the trials of Dawn and Diffuse. So this was in 2018. So considering all these publication results, the 2018 guidelines are published. And since then, the stroke interventions are being done up to 24 hours, depending upon the infarct core. So these are the initial trials which were published in NEGM, the ESCAPE trial, Mr. Clean trial, as well as the Extend IA trial and Diffuse and Dawn trials. So these 2 trials are the late window trials, which were positive for good outcome up to 24 hours, with some specific selection criteria based on imaging, not just on the time. Because sometimes time may not be the criteria in stroke. Time is always a criteria. You can rush into you need to rush the patient as well as possible for the treatments. But sometimes the patient gives some time because of good collaterals. Who are those patients who will give time till we do intervention and without any further deterioration? So that can be determined by the imaging, and that those patients, if you do interventions, the patients are going to be benefited. And that definition of criteria as well as the results were published in these particular 2 trials. So evidence for MT was enormous, and the number needed to treat was significantly low as compared to rest of the medical managements. And all of them patients showed in the various trials showed the good odds ratio, and this the forest chart showing that the propensity towards intervention, mechanical thrombectomy, better MRS in most of the trials. It is more than one in most of the cases. So this was the trial results. And what is so based on these trial results, the evidence, the guidelines have been framed by the ASA and AHA. And as I said before, that if the patient is more than 18 years and the causative occlusion is in the artery, and if you are doing the treatment within 6 hours, and if the aspects is 6 or more, or NHS 6 or more, then there is a class one evidence for thrombectomy. And this is one of the few first cases of ours having the in 2015 or so. And we can see the left M1 occlusion get treated by the stent reaver technique. And there is this important the guideline that once you give, if you are going for bridging therapy, this patient has come in the window period of probably 3 hours or 2 hours, and you are planning for bridging therapy, and you are giving the thrombolytic, and patient is having simultaneously on the imaging found that there is large vessel occlusion, and there is no need to wait for the response to be assessed. Patient can be directly shifted to cath lab for further intervention, because the thrombolytic efficacy in treating the large vessel occlusion is ranging from 5 to 33%. In MC occlusions, in M1s, it is around 30%, whereas in IC occlusions, it's only 5%. So instead of waiting for the treatment response, patient to be shifted to cath lab, and if the patient shows good reconstruction of the vessels and with simultaneous improvement of the clinical status, probably you need not do any thrombectomy. But if the patient is having no reconstruction, obviously you go ahead and do the intervention with the IVTPX still going on or completed. So the evidence is very clear that you should not wait for the IV2PA2 assessment to be completed and directly shift the patient for cath lab. So these are the guidelines depending upon the diffusion and down trial. The criteria based on the diffusion weighted imaging core or the perfusion, and you can plan for thrombectomy in those cases up to 24 hours. And regarding rest of the locations like post-cerebral artery, the cerebral artery, the evidence is not very robust. It is only class 2B evidence. And similarly for the patients who are having the occlusion at the distal M2 or M3 segments also, the evidence is not great. And for the patients who are having large infarcts, that means aspects less than 6 are very mild disability. That means NHS is less than 6, or the patient is having pre-scored MRS disability is there. In those cases also, the evidence is very scarce. So what we conclude is that the evidence says that you need to take up the patient for large vessel occlusion within the window period if the aspects is 6 or more. And if you're going for up to 24 hours, we need to select the patient stringently based upon the infarct core, whether it is small or not, by quantifying the overall the infarct core, and the energy should be 6 or more. And in distal vessel occlusions and large infarcts and mild disabilities, the evidence is not that great. So this is the conclusion of all the studies that we have discussed in the last few slides. So what is our protocol and how we treat and what is our experience, I'm going to tell in a few slides. So once a patient reaches the hospital with the symptoms of either face, arms, with the fast symptoms, so first we do the imaging. Our imaging is predominantly MR-based imaging. And after that, if the patient is eligible and if the patient is coming in within the window period for IV thrombolysis, patient is started on IV thrombolysis. And in 20 to 30% of cases, as I said before in the first few slides, that patient may be having large vessel occlusions. In those cases, not all cases of strokes, those large vessel occlusions, which account for around 20 to 30% of cases, we go for stent treatment or mechanical thrombectomy. And after that, patient will be shifted to stroke unit for further care. So this is very important that we need to coordinate all the corresponding human consists, starting from neurologist and ER physician, critical care experts, and neurosurgeon, interventional radiologist, neuroimaging specialist. Everybody should be 24/7 available, and everybody should be coordinated in a parallel manner rather than a series manner. And if you're working in a corporate hospital, obviously the administration, billing department, everybody to be included in the overall coordination team. So And the bottlenecks are always there. So we had our own difficulties in sorting out those bottlenecks, because this is not going to be very smooth and linear kind of thing. And we expect too many things to go wrong in execution in a time-bound manner, because we have the imaging issues may be there, and decision-making issues may be there after the imaging. And you may have issues with the logistics in the form of finances, consent, and all those things. And we had initially the problems with cath lab availability, because only one cath lab was running, and now we have got a neuro dedicated cath lab. So that got sorted out. So these are all the issues that we get come to know that once we execute our plans, and these are not easy to be sorted out in any situation. So once the patient comes to the ER, so we get this kind of stroke code, and with the time, and all the concerned persons like ER, radiology, neuroradiology, IR guy, and neurosurgeon, neurologist, everybody involved. The neurologist is the first guy, first doctor who is going to get the call, and after that, all the coordination start. And they, once stroke is diagnosed, we get a voice call as well as a message call, so that everybody is in loop, and everybody can take the combined decision which is best for the patient. So we had around 120 cases treated at our hospital in the last 4 or 5 years. And for anti-circulation strokes, we go with MRI with MR angio, who are coming beyond 4.5 hours, and who are patients who are of less than 4.5 hours, we go with the CT. So the protocol is very simple, that you do the combination of the CT and CT angio, or MRI with MR angio. And the patient is having large vessel occlusion, we do both intravenous thrombolysis with mechanical thrombectomy. And if the patient is beyond 4.5 hours, we go for mechanical thrombectomy. And if the patient is not having any large vessel occlusion, then only IV thrombolysis if the patient is in window period for 4.5 hours. So the results, the data of our patients, most of our patients were male patients, like it's like 3:1 ratio. They were there, and mean age is around 50. And we are seeing more and more younger patients because of the COVID reason, and they may not be having COVID, but we are seeing off late in the last 1-2 years patients who are of 35 software engineers. And recently, last month, we have treated a guy who is 17 years old with an MC occlusion. So we are seeing more and more younger guys in our population who are having large vessel occlusion. And the mean window period, as compared to Western studies, that many of the patients reached late after trying out their hand in few other hospitals in the periphery. So the mean window period is very high as compared to the Western studies, which is around 4 hours, less than 4 hours. We get the most of the patients around 8 to 9 hours. And mean NHS is around 15. And aspect score, we get borderline patients, as because patient is reaching late. That means the more infarction must have already happened. So the mean aspects is also on the highest side. And after the 120 cases, we had 100 in the anti-circulation and 20 in the post-circulation. And the patients, almost 30 patients underwent IV thrombolysis by the time we took the patient for the thrombolysis. So this is how a clinical case looks like. So this is the left IC, left M1 occlusion. You can see that she's having complete left hemisphere teratostrophy. She's having aphasia as well as right upper limb and right lower limb weakness. And this is after 8 days she came walking with minimal disability. You can say very minimal disability. So what we did basically we did imaging, and we did the angiogram, and we selected the patient about depending upon the aspects. The infarct core is small, and we went ahead and removed thrombus. And this was a post thrombectomy image, and this is the plot. So another patient. So these are the kind of patients that you get. If you get good results, that could you get very good satisfaction. Like this patient is pregnant. She is 6 months pregnant and 26 years old, and she presented in the window period of 5 hours, and thrombolysis was not done because she presented around the borderline zone, like 4 hours or 5 hours. Thrombolysis was not done because thrombolysis is not indicated. The role is not very clear in pregnant patients. The thrombolysis was not done. So we took the patient directly for thrombectomy with all the radiation protection measures. And in the first pass, we could recanalize the vessel. And this is very important because if with the conservative management, what kind of outcome she is going to get with such a large vessel occlusion, even though initial infarct core is small, and what kind of overall medical management patient is going to have, and what kind of effect it's going to have on the infant. The baby is also very unpredictable. So this patient had immediate on-table recovery, and she got discharged on day 2. So sometimes you see such kind of miraculous results. If the patient reaches in time and the patient gives us some time, the brain gives us some time in the form of good collateral. So we get such kind of results. Another case, this time again the left MCA occlusion, and we try to recanalize. And again, this patient, you can see that he's having on-table recovery. So this is not, probably I see such kind of cases maybe in 2 in 10 cases, maybe every one case in 5 patients. In 10 to 20% of cases, we get such kind of patients who are reaching in time, having less infarction size, the baseline, and having good collaterals. So another patient that right MCA occlusion this time with a reasonably moderate infarct, and we try to recanalize, and this is the thrombo extracted clot. And you see that the patient is moving here, and we don't give general anesthesia for all the patients unless until the patient is already GCS poor and there is problems with airway. In those patients, we try to intubate. Otherwise, we do under local anesthesia or under conscious sedation in most of the situations, so that we can assess the patient on table also what kind of recovery patient is having. And we have a carted Dyna CT that we can do a CT scan within the cath lab itself so as to see any complications related to the procedure like hemorrhage, all those things. And he is also having, you can see that he presented with left-sided weakness, and so you can see that he tried to lift the left leg immediately after the procedure on the table itself. So this is, and he was again. This was the status and day 2. And we do treatments out of the guy, sometimes, not always, some out of the maybe few in selected patients. Like this patient was a 27 male, and the entire MCA got infarcted. Probably the aspects, if you count in this case, it may be not more than 2 or 3. But still, we went ahead because the collaterals were good, and we did it because he's an young guy, and he had to undergo craniotomy because of the already existing infarct which was swelling up. But we could spare the frontal lobe, which is responsible for the motor functions. So this was almost on day 10 that he was started walking, although he's having such a large infarct. And because we could recanalize the vessel, so overall outcome is definitely is going to be better if you plan those cases in selected patients, not in all cases. So again, this is a relatively young patient, 43, having large MCA infarct. We try to recanalize, and this patient was having complete IC occlusion on the right side on the MCA. And you can see that this is a post-op CT showing only small infarct. This all depends upon the collaterals and the brain plasticity. So in few patients, if you take such large infarcts into case selection, that you may end up burning with your hands, and in few patients, they may do very well. So if you go by protocols, definitely the results are reproducible. But if you go beyond the protocol, you need to be very cautious in selecting those subset of patients. So technical outcome, we had a technical outcome. That means opening up the vessels. We went inside, but we are not able to open up the vessels. So such kind of situation happened in anticirculation 12% of cases, and in 88% of cases. That means 88 out of 100 times we were successful to open up the vessel. And almost in post circulation also we were successful in around 85% of cases. And as you see here, the successful opening of the vessel doesn't translate into a good outcome, because there are so many other issues to be concerned. One is that the patient may be having significant volume of infarct already by that. So the infarct is different and the vessel is different. We are opening up the vessel, but the infarct, if it is already if it's a more eloquent infarct and significant volume of infarct, then the outcome is not going to be better. So we need to consider the parenchymal findings also. So in our study, we could find that our outcomes are in the range of 70% in anticirculation. And obviously, post-circulation, my experience is not that great. We only had 30-35%. Only 1/3 of patients had good outcome, because most of the patients came in the late window, around 18 hours, 24 hours. And by the time most of the patients had borderline brainstem infarcts and cerebellar infarcts. So we tried to do in selected patients, but that the outcome was positive only in 1/3 of patients. So the guidelines are also not there for post-circulation. As we discussed in the few previous slides, all the guidelines are meant for anti-circulation. There are no guidelines for post-circulation. There are not case reports, case series, and in few cases we had to do young patients and probably having less imaging infarcts, but overall the outcomes are going to be poor in case of post-circulation and strokes as compared to anti-circulation. And these are our results, and these are the trial data which I described in the few previous studies. So we had the favorable outcome in the range of 70%, good reconnaissance in the range of 88%. The mortality was, this is all-cause mortality, it's almost in the range of 20%. The reason being that many of the patients are having the comorbidities. 2 or 3 patients died because of the comorbidities, like they are having rheumatic heart disease and repeated emboli because of the cardiogenic shock, heart failure, they succumbed, and few of the patients succumbed to the the large infarct course we selected, and they had symptomatic hemorrhage conversion, and for further treatments, they were not willing, they were not affordable because of the logistical reasons, so they had poor outcomes. So, but the outcomes are equal or maybe better than what is being described in the Western literature or in the trials. And our window period, as I said before, it is quite significantly high as compared to the Western trials, where the awareness is better and intra-hospital trials, stroke trial systems are better. So our window period is around 9 hours, whereas their window period is around, average window period is around 4 hours. So this is a graphical representation charts showing that our result, the technical outcomes are comparable, better than that of the Western data. But those data which they were published were in 2015. Obviously, with years of experience, people may get better reconnaissance. But our reconnaissance stands as of now at the range of 80 to 90%. And good outcome is comparable with the rest of the data. It's around the range of 65 to 70%. And mortality, for the reasons I described in the previous slide, is higher in our study because of the various reasons, logistics related to a private hospital where the patient has to pay from their pocket. And if the outcome is the short-term outcome, if it's not good, patient is not going to pay further, and they may not be willing to spend more time in the hospital for recovery or rehabilitation. So we do encounter complications. Complications are seen in the range of 10 to 20%. Technical complications less than 5%, and overall complications in the range of in the form of either symptomatic hemorrhage or edema. We see in around 10 to 20% of cases. This is a post-circulation stroke having vertebral basilar occlusion. We tried to open it up, and it was closing again and again because of an underlying plaque. We tried to balloon it, and it maintained nicely. And this was post-op day 2, and post-op day 3, whatever the infarction is there, because we put the patient on antiplatelets, he had bled within the infarct, and he had to undergo the craniotomy. And so this is very interesting and intriguing subset of patients, the neuro COVID with ischemic stroke. I have done around 3 patients, while 2 patients did well and 1 patient didn't do well. So the outcomes are not that great. And this patient had right IC occlusion and aspects borderline maybe 5 or 6. And I went ahead and did the thrombectomy, as you can see here. The IC got opened up and M1 got opened up, but you see that there is a plaque under overlying here. And the vessel got reoccluded on the table, very resistant with clot. Although it got opened up again, they reoccluded, and she started developing entire MC and malignant infarction. And they went to Lama for the obvious reasons that she is having COVID as well as the malignant infarction that is in place in the right MCA. So the literature also says the same, that generally poor outcomes after intervention in patients having COVID-related large vessel occlusions. Reocclusions and distal emboli are common, and patients, if the imaging criteria are low, that patient need to be on anticoagulation antiplatelet therapy perioperatively. So to conclude that stroke is not a single man's effort, it's a team effort, and neurologist is the leader, and we play part in probably 15-20% of the cases with large vessel occlusions. If all the logistics go in right direction and if the patient is willing and if the patient come in the time, this is how our role in the overall stroke care. Thank you.
Yeah, thank you, Dr. Suresh. I think your experience, your work speaks about your credibility and your expertise. We heard about the MR clean, escape, or the trials with different names across the globe. But what we can see here in the city of Hyderabad in your organization, the amount of work you are doing. We will take you through the few questions from our audience, then we will discuss across on the different other areas. So one of our colleague from Palmo, Dr. Harikishan, has inquired about if you have done a procedure, thrombectomy on a patient with acute atrial fibrillation and post-atrial fibrillation, this patient developed a ischemic stroke and you have done a thrombectomy. How frequently these patients need imaging, and particularly before they go for some airway procedures, do they need any imaging again?
Yeah, imaging in the sense that our standard protocol, we do a 24 hours check CT or check MR to look for any hemorrhagic conversion. And if the infarct is small, the post-operative baseline infarct as well as if there is no new infarct, usually at the time of discharge only, before discharge we do an imaging. Otherwise 24 hours check CT or MR is the standard. And if the infarct is large in volume, obviously we need to do more frequent, probably every 48 hours or 24 hours, or depending on the clinical situation. If this is worsening, then we need to do an emergency CT or MR to see for any edema, hemorrhage conversion, all those things.
His question is how frequently later part, once his patient gets discharged and comes for airway procedure or other procedures, how frequently they need imaging?
Sir, one at the time of discharge, and I don't think so. If you want to evaluate the cause, probably you need to do a CT angio or the other studies, but usually we don't do. For ischemic stroke patients, we don't do any follow-up imaging or CT or MR if the patient doesn't have any new symptoms.
Yeah. So if clinically the patient remains stable without any new onset of symptoms, you don't need any standard imaging technique before you discharge.
If the evaluation is incomplete, then probably you need to do a CT angio or vascular studies in the form of Doppler, all those things at the time after discharge. Or if the patient is having a residual thrombus in the ICA, you need to see whether the thrombus has completely resolved, the free-floating thrombus is there. So in such cases also, you need to get a repeat imaging. Or if you put a stent already in the carotid and you need to see the overall patterns of the stent long term, then the protocol is different. We do it 1 month, 6 months, and 1 year, the stent patterns, and every yearly after that. So those are all the protocols for any stents we have put in place. If the patient is having any residual lesions, then we need to do an imaging. So parenchymal, if you don't have any symptoms, there is no need to do imaging.
Yeah, we have Dr. Prusti from intensive care. His query is, when they do a perfusion MRI and perfusion study, what are those indications which actually makes them to think about going for a thrombectomy after a thrombolysis or before a thrombolysis itself?
Yes, sir. It's a very relevant question. So perfusion study is described in, there is no classified evidence for perfusion study in patients who are coming in less than 6 hours period. That is very specific guideline that they have made. That means you need not do a perfusion study, and for the lack of perfusion study, you can't deny the patient a stroke intervention. So patients who are coming within 6 hours of period, simple CT imaging or an MR imaging with diffusion with an MR angio study or CT angio is sufficient. And for those patients who are beyond the 6 hours and up to 24 hours in the diffuse and down trials, they have gone either with the perfusion study or with the diffusion core imaging, either of them. So if you have a diffusion MR, which we can do, and if you quantify the diffusion core, and perfusion can be, if it is not there in your setup, that can be, then it can be avoided. You can go just with the diffusion MRI. Regarding the perfusion, if you want to do the perfusion study, then there are 3 parameters that we need to interpret. That one is the cerebral blood volume, cerebral blood flow, and the MTT, mean transit time. Depending upon that, we'll calculate the volumes of the penumbra, volumes of the core, and then we'll decide whether the patient is going to get benefited by the thrombectomy or not. So the core is large and the penumbra is small. Definitely, obviously, there is no role for intervention. Patient has to be continued on conservative management or the best medical management. The penumbra is significant, then obviously we need to go for intervention.
Yeah, there is another question that what is the role of a low dose intraarterial thrombolysis in case somebody has a contraindication for intravenous thrombolysis, or you have a posterior circulation stroke with beyond 4.5 in between 6 hours? What are the role of intraarterial thrombolysis low dose?
Yes, sir. There was many studies previously, probably in, starting from late 90s and early to maybe early 2010s, the first decade of 2000s. Of late, there is no classical evidence for thrombolysis, intraarterial thrombolysis, but anecdotally people do it, especially for red thrombi. If you think that red thrombi is there, up to 10 mg of altiplase we give, we'll try to see. And I had the opportunity to see a few cases being treated with intraarterial thrombolysis. One of the case was the cardiologist was doing an ASD device for a young patient. And suddenly she had a left-sided IC occlusion. That means she manifested with aphasia and right hemiparesis on the table. So I was doing case in another lab. So I thought they called me intervention. So I can't discuss further case because that was an emergency. So I thought like you cannulate the ICI, just give some thrombolytic and see. So they gave around 7 ml of 7 mg of altiplase, and the entire ICI got open because it was kind of red thrombus, and the window period is almost less than half an hour because it was detected on the table, and she had complete recovery in the table. So that was wonderful. So it has got definitely effective, but there is no class one evidence, and because this is not going to be standard. So if it can be successful in 20-30% of cases, but in what will happen in those 70-80% of cases, once you give thrombolysis, whatever the devices you are going to put inside the brain, it is going to cause more risk to the blood vessels because of the shear injuries we produce. We produce kind of traction injuries, minor perforations that are going to be major complications if it is associated with preceded by intraarterial thrombolysis. So intraarterial thrombolysis in some other cases can also be was also advised, like you did thrombectomy and after that you found some small distal emboli, and to complete the procedure you just gave a like a bolus of intraarterial thrombolytic at the end of thrombectomy to clear up these small emboli. That is also one of the maybe anecdotal case
Dr. Suresh, how do you identify on table whether it is a red clot or other form of clots, and what is the dose you use?
Means red clot before retrieval, we need to decide everything before retrieval. So imaging helps us. So MRI if you do SWA or GRE, or CT if you do. So MRI SW will show that if the blooming is there, the clot will bloom. Hemorrhage will bloom as well as the clot also will bloom. So in the MC occlusion is there. In the M1 segment, if you see that extent of clot, you can see. And if it is blooming, blooming means it is dark and it is larger than its usual caliber. So that if it blooms, then it suggests that it's a red thrombus. So that is one of the indicators that the patient is going to respond to simple thrombolytics. Red thrombus usually lyses and it responds very nicely to thrombolytic. Whereas the white thrombus is a very tricky one. Sometimes it will be very rubbery, and we will have very much difficulty retrieving with devices also sometimes. So red thrombus is there means definitely patient is going to get benefited.
Okay, there are questions like in what situations we see some of those situations where thrombolysis is contraindicated. One of those situations you said pregnancy can be a relative phenomenon. Some of the times we have some surgeries done where thrombolysis is a contraindicated. Some are on high INR. Some are the relative contraindications for IV thrombolysis. In those situations, directly going for thrombectomy without waiting for a thrombolysis, or situations where you can directly go as a thrombectomy. What are those conditions where you can do that?
So directly going for thrombectomy, obviously the first reason will be patient coming beyond 4.5 hours. So our patient coming at 4 hours or 3.5 hours, and by the time we do imaging and we do counseling and they are willing, it will be the golden period will be over. So those are the times that we had to take the patient directly for thrombectomy. That is the most common the practical situation that we encounter. as you said, sir, like the patient is, and in-hospital strokes, all in-hospital strokes, most of them may be having like patients who are in cardiac ICU, and patient may be on high dose anticoagulation, high dose antiplatelet therapy. So in those cases, definitely the thrombolytic therapy is going to be moderately risky, and it's not absolute contraindication, but obviously it's going to be more risky. So in hospital strokes and post-operative strokes, patient has undergone major surgery and he developed a stroke. So those are all the situations where the thrombectomy has got the direct definite role, wherever there is contraindication for relative or absolute contraindication for thrombolytic. And the other one being large clots. Large clots, like IC occlusions. IC occlusions, if they are there, and the response of the IC occlusions to the thrombolytics is maybe in the range of 5 to 10%, not more than that. And if the patient wants only one treatment, probably our team will advise for a direct thrombectomy rather than a combination of treatments.
Okay, there was some interesting queries from Dr. Pawan. He asks if your thrombolysis will increase the risk of bleeding anywhere. So how safe it is to puncture a artery that is such a high use caliber of femoral, and what are the complications related to that?
That is a very relevant question. We get that question whenever we take the patient to cath lab, and our anesthetists ask the same question. You say that you should not put a foliage, you should not put a line after thrombolysis for 24 hours, but you're puncturing a major vessels in the leg, and there are no contraindications for you, and there are contraindications for us.
Yes.
So how does it
justify?
Make sense. So most of the times it's thrombolysis related complications outside the brain, we never encountered because the half-life is very short. Practically, the reason being half-life is very short. It's in the range of 18 minutes for altiplase, and technically also it's also almost in the same range, I think less than 30 minutes. So even if sometimes we do thrombectomy when the thrombolytic is still going on, infection is going on, with the wire going inside the brain, and so not very much worried, but still that iota of doubt will be there. If I perforate this vessel, definitely it's going to bleed. But outside the brain, it's less risky. Within the brain, if something perforation happens, definitely it's going to be more risky. More hemorrhagic conversions we have seen. But thrombolysis per se, but if you take into controls, if you've taken patients have the same aspect score and you've done directly empty, and if you have bridged with, if you take the time component out, and if you compare the patients of the same imaging and same level of occlusion, and in one patient, in one cohort, we have done the only thrombectomy, and another cohort thrombolysis thrombectomy, the outcomes are not different, and the complications are not different as far as the brain is concerned. And that means IV thrombolysis in any way is not going to increase the overall risk in a set of population. Maybe in individual patients it may happen, but in overall set of patients, it's not going to additionally increase the complications. As far as the systemic complications is concerned, there are certain things we can take into consider, like we can take precautions, like if you're accessing the femoral vessel, try to do a single wall puncture. Try to take the help of ultrasound while puncturing the femoral artery. If the patient is very irritable and if the patient is very obese, you're not very confident of hitting the vessel in one go, then obviously taking an ultrasound help is going to add up to the safety of the patient.
Yeah, so there are some other interesting queries across. Dr. Misra had a query. He felt that like our primary PTCS, which we do in the middle of the night, and it became a norm that any ST elevated MI reaches the hospital, which has a facility. So directly wheel into the cath lab, open the vessel. So do you think in the future we are looking forward for a intervention like that, a stroke patient reaching in window period should wheel down for a cath lab, take an angio, decide there whether you need to open up that vessel or give a thrombolysis and do that? Will that be a process in future?
It's a futuristic question, very interesting question. There are two things that we need to address here. That we are talking interventions only in large vessel occlusions. So in anyway, in medium vessel or small vessel occlusions, we are not going to get any interventions. That is for sure for the next 100 years also. So we are talking about large vessel occlusions, and that the technology, be better technology, better imaging technology, better time saving technology. So large vessel stroke incidence is not going to go up. So all the strokes are not going to require intervention for sure. So for those patients who are potentially large vessel occlusions that we can clinically assess, like with NHS more than 12, we can say that it's a probably large vessel occlusion. We can rush in those patients directly to cath lab. And there are certain newer cath labs which are coming with certain vendors with a CT perfusion, CT angio facilities, everything in one go in the cath lab itself. So such kind of imaging advances, if they are they're there, which are like kind of hybrid imaging technologies. If you have in the cath lab, definitely is going to rely reality. And there are many centers in the West, especially in US, who are doing those protocols where the patients are getting directly rushed to the cath lab, depending upon the NHS score. NHS score, if there is more than 12 and all, they are selecting directly rushing the patients to cath lab for possible large vessel occlusion treatment.
Okay, some interesting other queries that you spoke about more of the intracranial large vessel occlusions, mainly arterial side. What about the venous side? We see CSVTs commonly now in COVID era also. In the other way, we also see many CSVTs in younger age group patients. What is the role of thrombectomy in those patients?
Very relevant question, sir, because venous strokes are also as common as arterial stroke in our side, especially in tropical countries. Um so, as compared to arterial strokes, venous strokes they do respond very nicely with the anticoagulation. Almost the literature says that, as well as our personal experience says that 90 to 95% of the patients they respond to medical management, not even thrombolytic, simple anticoagulation, either a conventional or low molecular heparin. So, in 95% of patients they respond to medical management. There are subset of patients in which intervention is going to be helpful, like if the patient is coming in a poor GCS, if the patient GCS baseline GCS at arrival is 8 or 9, with the massive involvement of all the sinuses or probably infarctions, venous infarctions everywhere, and that is one category of subset of patients where thrombectomy is indicated. The other one is patients who are not responding, deteriorating day by day with anticoagulation. These are the two subset of patients. Third one, relative indication is deep CSVT, means involvement of straight sinus and deep venous sinuses or intercerebral veins. So these are the three indications. Otherwise, most of the patients will be treated and will be treated successfully with anticoagulation alone. So the first subset of patients are patients who are on like on our arrival itself, the GCS is very low, and there is no window period for the patient to be treated by anticoagulation. So you need to just remove the clot out as much as possible and get the antigrowth flow established. And what we do is the same, similar to that of the arterial thrombectomy. We go with the venous route, going to the IJV, from there into sigmoid sinuses and the superficial sinus with the same kind of device that we use for the arterial side. And we try to debulk the clot within the sinuses as much as possible to establish the flow.
Yeah, Dr. Suresh, it is very heartening to hear about these all interventions, which are probably very few centers, even in the so-called developed and resourceful countries. But in the resource-limited setups like India, maybe very few limited centers having these facilities. And you rightly pointed out the functional outcome and the disability-free days will be your target. So in this situation, in the context of India, where these facilities are limited, available in very few centers, what is your actually take message for the centers or the specialists who are available in the peripheries where there may not be facilities for thrombectomy or interventional radiology? So what do you say to them that once they reach to that hospitals, if they get a CT, or if they have an MRI, they do MRI DWI? So many of the centers probably now are equipped to at least get a thrombolysis done. So what is your message to them?
Very relevant question in our setup, sir. So in Western population, Western studies also, almost till now also, around 20% of the patients of their overall practice, they do telestroke. They start with thrombolysis done. They get the thrombolysis started, and then they ship the patient to the referral center. So this is called as a drip and ship method.
Yes.
Where in the drip and ship method, and Yashoda Hospital also, and our stroke neurologist Dr. Komal Kumar also has come up with this idea, and we have started 2 years ago with this concept called as stroke care on wheels, stroke on wheels, or stroke care on wheels, where in the patient with the help of telemedicine or teleimaging, CT or MR being done in the periphery, and if you diagnose that there is ischemic stroke by ruling out the hemorrhage, and then you start a thrombolysis there and ship the patient to the referral center. So this concept is very much in existence in the Western society, and it is for the betterment of the patient. And we can implement and collaborate with the centers in the periphery, and we have been doing it. And we have one of the first to concept, our stroke neurologist as well as our administration are one of the first to conceptualize this kind of strategy to get the patients to get the benefit, the most of the benefit to the most of the patients.
Yeah, but it is not just periphery, Dr. Suresh. Even in the cities like Hyderabad, I'm sure it will be limited to very few centers who have a expert like you available, and probably the many other centers may be treating stroke patients. Is it the part of awareness, or it is a core teamwork where you have to coordinate, or all the clinicians to come onto the same platform to help the patient's recovery or disability-free days? Do you think that's a part which we need to probably focus in the futuristic way?
Yeah, that's a very good advice, sir. Like we need to talk to more physicians and more neurologists and show our results. What kind of results we are producing, in what kind of subset of patients, and patients who have been already thrombolyzed in outside setup and they've been transferred, and we are doing thrombectomies if there is a large vessel occlusion. So in those subset of patients, what kind of results we are producing, we need to talk and show to all the referring physicians who are probably 60 kilometers, 70 kilometers of radius from here, who may get benefit from the further treatments. So we need to create more awareness that such kind of facilities are available and such kind of treatments can be given in a time frame manner, and what kind of triage system we have in our hospital. So we need to talk more and more and more, create more awareness among the society, among the physicians, among the neuro community.
So there were some questions like untreated OSA patient, how often they present with stroke? Is there any risk involved in OSA patients?
Practically, I don't have any experience.
Yeah. So I think the OSA patient will have risk for accelerated hypertension document. Hypertension will be more common in them. Maybe hemorrhagic strokes may be more precipitating than ischemic strokes in them. Dr. Suresh, I think it was an enlightening talk to many of us also. You actually focused on saying that time is brain, and you have shown so millions of neuronal cells die every minute. So now we have already started focusing, not just our organization, across the globe and in our country, in our city also, that the stroke has been recognized as an emergency, and many stroke codes has been evolved, including our own organization. The other part you said during imaging, if the patient reaches in window period, CT or an MRI with a DWI can give you an immediate clue without a bleed. And as you said, this can be dripped and sipped from different areas to our hospital, or in our hospital, that will be an immediate imaging with, you said, MR angio, which you prefer, and see if there are large vessels involved. And particularly you said if the internal carotid to the intracranial vessels and the main M1 segment, you feel always a add-on thrombectomy will be on card. But you again spoke individualizing each patient, the core, in fact, the penumbra area, and that is your decision making on the basis of that. So that needs an expertise and skilled person to evaluate and act. So I think we had many questions, but with the restriction of time, I think we will take those questions later on in a Facebook. And I thank all the audience, all the participants, and Dr. Suresh Giragani in presenting and enlightening all of us. Thank you, Suresh. I conclude the session.
Thank you, sir. It's a pleasure interacting with you regarding all the aspects of stroke intervention. Thank you.
Thank you.